So today I thought I'd talk or do a 135 on fibromuscular dysplasia. So this is a condition which is defined as an idiopathic segmental atherosclerotic non-inflammatory disease of the arterial wall musculature, which leads to stenosis of small and medium-sized arteries. It's characterized by an abnormal smooth muscle cell proliferation within the vessel wall that leads to distorted vascular architecture. In about 3/4 of patients with FMD, they have involvement of their carotid and renal arteries. It's previously thought to be quite a rare condition, but some more recent studies estimate that it could affect about 3% of the population. It is usually diagnosed in middle age and predominantly affects women. They make up about 80% of those affected. And in terms of neurological sequelae, it can cause migraine, TIA, stroke, subarachnoid hemorrhage, and Hodder syndrome. In terms of its systemic effects or sequelae, the main thing is hypertension for patients who have involvement of their renal arteries. And outside of renal artery atherosclerosis, it's the second most common cause of renal vascular hypertension. So how does it present and how do we diagnose it? Well, as I was saying before, hypertension is present in about 80% or so of people with FMD, but up to 2/3 will present with either headache, which is usually migraine, pulsatile tinnitus, and dizziness. There's not much to find on examination, but you may hear a carotiduria on auscultation. And in most cases, it's often found incidentally on cross-sectional imaging. It can be unifocal or multifocal. In unifocal cases, you'll just get an area of stenosis or aneurysm within the affected vessel. The multifocal type is more common. And there, as hopefully you can see on this CT angio, looking at the internal carotid here, you get alternating aneurysms and stenoses in the vessel, which give the classical string of beads appearance. So how do we manage it or approach it? Well, there's no disease-modifying treatment for this, but consensus advice is that if diagnosed, all patients with FMD should get a once-off vascular imaging from their head to their pelvis. The reason for this is to assess what vascular territories are affected by the condition, and also to look for any dissections or aneurysms which may require intervention or surveillance. Then the sort of further management or approach depends on whether this has been found incidentally and is asymptomatic or whether it's symptomatic. In the incidental asymptomatic cases, the main thing is looking at patient risk factors, vascular risk factors, and deciding whether or not they may benefit from a low-dose antiplatelet. And for the symptomatic cases, there's not a lot of difference between the management of someone with FMD and dissection or migraine to someone without, but there are a few nuances. So, for example, in someone with FMD and migraine, you may want to avoid using triptans because of the vascular risk associated with that. So, take-home points, it's an uncommon but notable cause of cerebrovascular disease and headache, primarily affecting the young people, middle-aged women. It's probably more common than we previously thought. And not only can it have implications on specific condition management, like in migraine, but it can also have implications for long-term preventative therapy as well as surveillance. Thank you.